So today we're going to talk to you about how spots and fever come to us in neuro-op. And we're not going to cover all the infectious disease aspects, but when you have a patient who has a rash and fever and has meningeal signs plus neuro-op signs, you really should be thinking about the spotted fever groups. And the spotted fevers come in different flavors because they are arthropod-borne, and that means they have different vectors. And so you need to know a little bit about the different vectors. We have flea, tick, and the louse, which is the body louse. So for the flea, that's going to be Rickettsia typhi. That's our endemic form. Usually it's in cats and dogs, but also opossum in the wild. In the tick, that's going to be the Rocky Mountain spotted fever group. That's Rickettsia. So Rickettsia. And you don't have to be from the Rockies or been to the mountains. In fact, you don't even have to have the spots, but you do have to have the fever. And Rocky Mountain spotted fever mostly comes in our country from not the Rockies, from the Smokies and from Appalachians and North Carolina and Missouri. That's where kind of our Rocky Mountain spotted fever is. And the body louse causes the epidemic form of typhus, Rickettsia prowacheki. So Rickettsia typhi is the one we see here in Houston. It's like the city version of it because the flea and pets. And then the country version of it is the tick one, hiking, biking, walking your dog in the woods. These are all tested by serologies. And as you know, we got IgM and IgG responses. And so if you have IgM positive, that's evidence for an acute infection. If you have a rising or a very high IgG titer, then that's diagnostic. But if you got this in-between version, you have to show the titer is rising. That means you have to have an acute and a convalescent titer to show it's going up. And so normally the cut points are going to be like 1 to 128 or 1 to 256. So once you get the numbers like 1 to 512 and 1 to 1024, those are positive. Or if you have IgM positive, that's pretty much acute infection. You do the IgG to show that it's rising titer. And the reason it's important in neuro-op is they start with constitutional symptoms, fever, then they get the rash, spots, then they have the nausea, vomiting, headache, and the stiff neck, photosensitivity. And so what we're going to be called for in this setting is they're going to have blurry vision, and we're going to be looking in their eye. What we're going to be looking for is papillitis, the disc is swollen, papilledema from increased intracranial pressure, and the retinitis, which can show up as hemorrhages or fluid in the macula, cotton wool patches, infectious neuroretinitis. And OCT is really great in these cases because it can help differentiate whether we're dealing with an optic neuropathy or are we dealing with an inner or outer retinopathy. And really, you can't see that to the micron level, but OCT can. So we're going to do OCT of the nerve and the macula in these cases. And while we're waiting for the serology, we're going to treat the patient empirically with some sort of tetracycline, usually doxycycline, and they're going to get better real quick. So you should be thinking about the spotted fever group when we have spots, fever, constitutional symptoms, the neuro-op findings, swollen disc, retrobulbar optic neuritis, papillitis, papilledema, and infectious retinitis. We're going to do OCT on these people, serology, IgM, IgG, and treat them with doxycycline.